Today we're doing the Chronic Pain Conundrum webinar with Dr. Barry Sessle, and this is the first webinar in our new series called Chronic Pain, Improving Life While Living It, and we're very glad that you could join us today. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with Canadian Institute for the Relief of Pain and Disability, also known as CIRPD. And this webinar is co-sponsored by CIRPD and Pain BC, and we've also been working in collaboration with the Canadian Pain Coalition. This webinar was made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya, and I'm moderating the event today. We also have on the line Anne Gillespie, who is a coworker of mine, and she will be collecting the questions and helping with the Q&A portion at the end of the presentation. And our presenter today is Dr. Barry Sessle. Dr. Sessle is the professor and Canada Research Chair for the Faculties of Dentistry and Medicine at the University of Toronto. He is a past president of the Canadian Pain Society, the International Association for the Study of Pain, the Canadian Association for Dental Research, and the International Association for Dental Research. He is editor-in-chief of the Journal of Orofacial Pain and has co-authored and edited 11 books, published over 350 journal articles and book chapters, and delivered over 400 invited lectures. He's very experienced, and we are very excited to have him presenting today. So I'm going to go ahead and hand it over to him. Go ahead, Dr. Sessle.
Thank you, Tanya, and welcome everybody. Good morning or good afternoon or good evening, depending on where you're listening from, and to my French-speaking colleagues, bonjour. So I'm going to be talking about the chronic pain conundrum, maybe also be called the pain crisis, the silent epidemic. First of all, however, I want to provide some disclosures. I've had some interactions with Pfizer Canada, as you can see, with Lilly Canada, and my research grants since 1974 have been supported by both the Canadian Medical Research Council, which is now known as the Canadian Institutes of Health Research, and by the US National Institutes of Health. So I'm going to first of all start with a brief overview of recent advances in pain research and management, and then focus on what I see as the remaining challenges to the pain field, the pain area. And these I see especially related to pain awareness, pain education, to access to timely and appropriate pain management, and research. And I'll take each of these points in turn. And with each of these, I'll talk about some recent and future initiatives that are needed to address these issues, and recent ones that have been taken as well. So as far as the recent advances in pain research and management, there have been, since about 4 decades now, there have been some remarkable achievements in learning about pain, understanding pain. For example, we now know a lot about the nociceptive processes, that is, the processes in peripheral tissues or in the brain that involve neurons or nerve cells that respond to noxious stimuli, nociceptive stimuli, that is, pain-producing stimuli. And these are the processes that underlie pain. So, for example, if you look at the figure here on the top right, if we have damage to a peripheral tissue in some body part, that elicits signals in the form of nerve signals that are then conducted along the nerve fibers into the central nervous system, where these nerve fiber endings in the central nervous system, or CNS, then relay their messages. These signals are then relayed onto nerve cells within the central nervous system, and then these signals are then relayed through different levels of the brain, up to high levels of the brain, for example, up in the so-called thalamus, or at several cortical levels, where the perception and the experience, the many dimensions of pain that I'll be talking about, are experienced. Now, there's also, over this last for decades been the discovery of several endogenous neurochemicals, that is, chemicals that are released in the brain in these ascending pain pathways, or that are released from so-called descending pathways in the brain. Pathways, or as I point over here, intrinsic pathways in the brain that can influence pain transmission even at the very first synapse here. So there are these descending pathways originating from parts of the cortex, other parts of the higher brain such as hypothalamus or amygdala, as well as parts of the midbrain, the periaqueductal gray, or parts of the medulla, the rostroventral medial medulla. These are pain modulating pathways that involve several neurochemicals, and they can eventually affect the transmission process, even, as I say, at this first relay station, this first synapse in the ascending pathway. And related to this has been the development, particularly in the last 2 decades, of concepts and insights of the neuroplasticity of these pain processing and indeed pain modulatory systems. And it's through these neuroplastic changes in these systems that can be resulting to development and the maintenance of chronic pain states. So, for example, if we look at this part of the pain transmission system, the very first relay station or synapse in the pathway, this is a magnification of this region here. So we see the incoming nerve fiber supplying the peripheral tissues that are sensing the noxious stimulus. They release chemicals, neurochemicals, as I mentioned before. These chemicals include glutamate or substance P, and they are released at this synapse with the pain transmission neuron. So here's the surface of the pain transmission neuron in the so-called dorsal horn. And these pain transmission neurons contain ion channels or membrane receptors with which glutamate and substance P and other substances released from these nerve endings that are transmitting the pain signals. These chemicals interact with the ion channels and membrane receptors to excite the pain transmission neuron. But in some cases, the excitation can be quite marked, and through a number of intracellular processes that I don't need to go into today, there can be an increased or hyperexcitability of these neurons, and it's this hyperexcitability, or so-called central sensitization, that's thought to be a crucial process leading to the development of both the development and the maintenance of a chronic pain state that may be expressed at all levels of the pain pathway. But all other advances in our understanding of pain has been the recognition that became apparent, I guess, about 3 or 4 decades ago, that pain is not just a sensation. We often think of pain as just being another sensation like touch or vision or hearing or smell. But in fact, it's multidimensional. There is certainly the perceptual aspect, as we see over here, the perception of the nociceptive pathways and their effects on the high levels of the brain. We can perceive the pain or sense the pain, but indeed there are a number of other dimensions of pain, so that we really think of pain these days as as an experience, not just a sensation, but an experience encompassing a number of other dimensions. The emotional aspect that may be evoked will be associated with the pain, the person's thinking or cognitive processes associated with understanding of the pain and how they may adapt, or as we see here, may not adapt or maladapt to the pain, how they may change their behavior, both in a positive or maybe in a negative, dysfunctional way, and maybe develop what's known as illness behavior. So pain is now looked upon as being not just a sensation, but really an expression of a biopsychosocial number of features of a biopsychosocial model. There have also been, particularly in the last 10 or 15 years, rapid advances in the fields of brain imaging and in molecular biology, and pain genetics is an emerging fields, and that are slowly being applied to the pain field. For example, studies in Canada, both in Toronto and Montreal in particular, this shows some figures from some of the Toronto studies from Karen Davis and her group in Toronto, showing different areas in the high brain, such as the so-called second somatosensory area, or the insular cortex, or the anterior cingulate gyrus, that light up, that become activated when a noxious stimulus is applied to human peripheral tissues. And then there are, in certain chronic pain states, so-called phantom pain or tension-type headache, chronic back pain, for example, frequent migraine, there are areas in the human brain that light up and become, their activity is maintained during these chronic pain states. And then there have also been, over the last 40 years, considerable improvements in the surgical, pharmacological, and behavioral management of pain. So the last 4 decades have seen remarkable advances in our understanding and knowledge of pain. I entered this field myself 4.5 decades ago, 45 years ago, and have been very fortunate to be part of and experience this upsurge of interest in and research and understanding of pain. It's been quite remarkable. But despite past and recent advances in pain knowledge and management, as I alluded to earlier, critical issues or challenges still remain in pain awareness, in pain education, in access to care, management of pain, and in pain research. There are challenges, resources, and funding issues in pain research that I want to touch upon as well. So first of all, pain awareness. First of all, we need to have some definitions on the table here. What do we mean by pain? Well, as I alluded to, it's really an experience. It's not just a sensation. And the International Association for the Study of Pain, or ISP, defines pain as an unpleasant sensory and emotional experience associated with actual, or in some cases potential, tissue damage, or what is described in terms of such damage. I also want to make sure people understand this term noxious or nociceptive. I also mentioned it earlier. So a noxious stimulus, for example, is a stimulus that is damaging or potentially damaging to tissues. So it's a type of stimulus that can result in pain and the pain experience by activating these nociceptive pathways that I mentioned before that occur in the brain. And then we have acute versus chronic pain. I'm sure everybody has suffered to some extent from acute pain. We've all experienced acute pain. It's a transient, usually sharp pain that serves a protective function. It warns the individual of actual or impending tissue damage. So if this person gets suddenly burnt by putting their hand too close to a flame, a hot or noxious heat stimulus, that is, there is activation of the pain nerve endings, so-called nociceptors, that then elicit signals that are carried along the nerve fibers, as I said in one of my earlier slides, into the central nervous system, activating the pain transmission neurons, and these signals are then conducted to higher levels of the brain. In addition, however, as I said, there are also these descending pathways that can modulate this pain transmission process. So it's a very dynamic neuroplastic series of mechanisms that are involved in the pain experience. Now, chronic pain, where we really see the neuroplasticity being developed and maintained, resulting in a hyperexcitability of the pain system, pain transmission system, chronic pain is considered to be persistent, often dull or aching pain that continues long after an injury has apparently healed. most people consider that that's a pain that's been in existence for at least 3 months, perhaps in some cases 6 months duration, as is what may be called a persistent or chronic pain condition. And most people feel that it really serves no protective function at all and serves no biological role, in contrast to acute pain, which, as I pointed out in the previous slide, is a warning signal to the individual to do something about this stimulus that's evoking this acute pain. So we have this number of chronic pain states, of which, oops, sorry about that. Go back one, if I can here. I don't think I can. Yeah, there we are, sorry about that. So we have a number of chronic pain states, in which one of it is illustrated here, a person with a particular type of headache, where it's clear that they're not just experiencing a mild sensation, but there's a complex, multidimensional experience that's part of their chronic, that is reflecting their chronic pain state. They may have, in this case, a throbbing headache. There may be a number of other changes occurring in the so-called autonomic nervous system, where there may be sweating and tearing. There may be vomiting as well. The person may become tense and irritable and confused and so on. So a number of changes in their brain are occurring in different parts of their brain, and it's expressed in a number of different ways. A real pain experience here. So acute pain is transitory, as I said, it persists just for a few hours, maybe 2 or 3 days, whereas chronic pain persists for 3 to 6 months or more. And chronic pain can be looked upon, or now looked upon by many of us, as really a disease state itself, a disorder of the nervous system, of the central nervous system, because of these functional and in some cases structural changes that are seen in the brain in certain chronic pain states. Chronic pain may be considered to be a neurological problem itself, akin, for example, to Parkinsonism or epilepsy, where there are structural and functional changes in the brain and changes in brain neurochemicals. Analogous changes, as I say, are occurring in chronic pain. Now, chronic pain may in fact be part of other conditions, such as HIV/AIDS or diabetes, for example, may express pain. Cancer is another example where pain is quite commonly expressed, and is perhaps the major concern of the patient as far as the quality of life. There are other conditions as well where we have chronic persistent pain that many of you are aware of, arthritis, fibromyalgia, migraine. But also about 20% of chronic pain states arise from an acute injury, where the acute pain has not been appropriately or timely managed, and as a result the acute pain state transitions into a chronic pain state, which may be either persistent or episodic. So it's the bottom take-home message here, that if you have an acute pain condition, it's very important to make sure you manage it correctly, have it managed correctly and in a timely fashion. Otherwise, there's a possibility it may transition into a persistent chronic pain state. Now, chronic pain is a silent epidemic, because almost 20% of Canadian adults suffer from moderate to severe chronic pain daily on most days of the week. So roughly 1 in 5 Canadians have a chronic pain state. And this is not something that's common, or just a feature, I should say, just of Canada. In the USA, comparable surveys have been taken where the figure is also around about 20%. Here we have Canada shown here on the proportion of adults who have a chronic pain condition. As I said, is around about 18% or so. But I'm showing this in terms of, in relation to other countries around the world, particularly in Europe in this instance, where surveys in Europe have found that in the adult population, anywhere from 12 to 30% of the adult population have a chronic pain condition. And so Canada is right up there in the middle as far as its relative comparison with European countries, and it's at a comparable level with the USA. I recently did a survey of pain or a literature survey of pain in Japan, and it's also around about 15–20%, it appears. And then there's the costs of chronic pain, and this is where the crisis really is evident. The personal cost to Canadians themselves, the person who has the chronic pain state, from surveys and published articles, it's clear that there's a reduced quality of life in the majority of chronic pain patients. It has a negative impact on their relationships with others. There may be job loss or reduced job responsibilities for the majority of chronic pain patients. For most of them, the majority of them, they feel that the pain is not effectively managed. There's a reduction in their self-esteem. There are also increased rates of depression in chronic pain states, and unfortunately there's also twice the average likelihood of suicide while waiting treatment for a chronic pain condition. And then from an economic point of view, the costs to Canada are just enormous. It's recently estimated that the cost to the Canadian economy of having patients with chronic pain, where we take into account the costs of medications, times off work, compensation, lost tax revenue as a result of not working, etc., etc. It turns out to be a whopping more than $30 billion a year. And that's as much as or greater than the cost to the Canadian economy of cardiovascular disease, heart disease, etc., and cancer combined, and much more than depression. And as I said, there's lost productivity and lost tax revenues. And then we have to keep in mind that changing demographics will in the future result in a higher proportion of the population of most countries being middle-aged and elderly. And this is the age cohort or group where most chronic pain conditions are particularly evident, and usage of the healthcare system is particularly high. So this crisis that we have at the moment is going to become more of a crisis unless something is done to rectify the situation. I also want to mention one thing before I leave this slide, this cost of $30 billion a year. It's probably hard for most of us to imagine what $1 billion is, let alone $30 billion is. But the comparable figure in the US is something of the order of $300 or $500 billion a year. And to put that in perspective, that's what it's costing. That's equivalent to what it's costing the US every year for financing the Iraq War and the Afghan War combined. And you know what that has done to the US economy. So the cost of pain to Canada and to US is just enormous from an economic point of view, as well as the personal costs to the patient who suffers from chronic pain. So what do we need to do? Well, we need to augment or increase pain awareness and pain education. And I believe that there needs to be 4 targets for this focus on pain awareness. We need to target the public and the media, the government and policy makers, healthcare professionals, and health science students. And some possible approaches to augment pain awareness to inform the public, government, and policy makers, media, to synthesize new pain-related information for widespread readership by healthcare professionals, to develop and widely distribute pain information sheets and articles of patients, healthcare professionals, government and policymakers, and to also collaborate with other stakeholders in these initiatives and inform and support mobilization of stakeholders such as pain advocacy groups. So Raising pain awareness, in fact, needs to be part of a coordinated pain strategy that addresses all these challenges in the pain field, and with an integration with recent pain awareness campaigns that have been launched nationally and internationally. At the international level, when I was president of the International Association for the Study of Pain, we met with the World Health Organization and started to develop ideas about having a global day, which is now a week, against pain, to increase public awareness of the problem of pain, and that the relief of pain should be a human right. So this Global Day Against Pain, which is now a global week or month against pain, or a year against pain now, was launched about 8 years ago. There are also national awareness initiatives that have been taking place, for example in Canada, where the Senate about 7 or 8 years ago, particularly through the efforts of the Canadian Pain Coalition, approved the National Pain Awareness Week. So every week, 1 week in November, there's a National Pain Awareness Week that has the objective of raising awareness about pain. There have been other initiatives, such as the Pain Explained initiative, which tried to coordinate and did coordinate the pain awareness and advocacy campaigns of the Canadian Pain Coalition and the Canadian Pain Society and the Canadian Pain Foundation. There are other pain associations that I want you to be aware of. The Chronic Pain Association of Canada, for example. There are regional and provincial pain advocacy groups and initiatives. Action Ontario, for example, is an advocacy group for people with neuropathic pain. There's its website here. And then there's the Association Québécoise de la douleur chronique, the Chronic Pain Association of Quebec, and it's made many inroads in drawing attention to chronic pain crisis to Quebecers. And also recently there's been a focus on increasing awareness through having pain summits. One notable advance was the Declaration of Montreal in September, which was organized by the International Association for the Study of Pain, and it's basically a declaration that access to pain management is a fundamental human right. You can get the details at the ISP website here, and in fact at an individual level endorse the declaration, and likewise a similar initiative at the Canadian level with the Canadian Pain Summit and the Canadian Pain Strategy, which also can be endorsed by going to this website here, Canadian Pain Summit 2012.ca. Pain education. We have problems also in pain education, knowledge transfer and application, and that's quite evident from a number of studies, including studies in Canada, that have shown undertreatment of pain in cases of cancer pain, HIV/AIDS pain, cardiac surgery, postoperative pain, neonatal pain, for example. Likewise, in my own area of orofacial pain, pain in the face and mouth, there's a number of papers that have been published pointing out the misdiagnosis that is quite frequent, the under or over treatment of pain in situations such as trigeminal neuralgia, atypical facial pain, and temporomandibular disorders. So clearly a problem exists in knowledge transfer and in the application of this new knowledge for effective pain management by clinicians. If we look at the pain curriculum, from the perspective of the pain curriculum, the curriculum that's provided about pain in various health professional schools, you need to keep in mind that pain is an integral component of dental and medical practice. In fact, one of the main reasons for patients visiting a dentist or a physician or other healthcare professional is pain. There's a high prevalence of pain conditions, as I pointed out in one of my earlier slides. For example, 18 to 20% of adult Canadians have a chronic pain condition. There's these huge socioeconomic costs of pain and the changing demographics, which, as I indicated, suggests that there could be future increases in the prevalence of pain and these costs. And yet, pain is a minor component of the curriculum of most health professional programs. There's a survey done in Canada, published in 2009, also again in 2011. Other aspects were mentioned by Watson and her colleagues. It was a survey of over 40 health professional faculties in Canada, from east to west, including dentistry, medicine, nursing, occupational therapy, pharmacy, and physical therapy, to assess the number of hours of formal pain content in the curriculum for the whole program, for the whole, for example, 4-year dental program. A total of only 15 hours was the average. And in some dental schools in Canada, 0. Likewise, 0 for some medical schools. The average, again, being around about a total of 16 hours. Nursing, a bit better. Occupational therapy and physical therapy, a little bit better. And yet, as a comparator, the survey also surveyed veterinary medicine, and the number of hours devoted in veterinary medicine schools for veterinary students is much more disproportionately high compared with these other programs. So what this means, in fact, is that our domesticated furry friends are getting pain management by people who are, by vets, in other words, who are much more knowledgeable about pain than clinicians who treat ourselves, humans. The competency requirements in pain are also limited. By that I mean that when a physician or a dentist, for example, is about to graduate, they have to have shown to have reached certain competency levels in a number of areas, and the competency requirements in pain are very limited. In case of dentistry, for example, whereas we're in Canada, there's something like 40 to 50 competencies that are required. Only a couple of them relate to pain. Similar proportion is seen for medicine. And so clearly a problem exists in educating students about pain. So some possible approaches that need to be taken to augment pain education is to increase pain curricular time for all health professional, health science students, to ensure that pain is taught in an integrated manner that reflects its multidimensional nature and within a biopsychosocial framework, to update and keep current pain curricula developed by the International Association for the Study of Pain, the International Headache Society, which developed pain curricula for each of the health professional fields and offered to be taken up by each of these programs. And also there's a need to ensure sufficient coverage of pain in the accreditation requirements and in practice standards for healthcare professionals, for hospitals and so on. And also a need to research and implement more effective means that ensure knowledge transfer and application of this new knowledge about pain mechanisms, pain diagnosis, and pain management. In Toronto, the University of Toronto, we took an initiative about 10 years ago to have an integrated undergraduate pain curriculum. So the students in the different health professional programs, dentistry, medicine, pharmacy, nursing, physiotherapy, occupational therapy, come together as a group for 1 week where this is a multidisciplinary, interdisciplinary focus on pain. And there have also been a number of recent initiatives in pain knowledge transfer by a number of groups across Canada to try and look at ways by which pain knowledge can be transferred and applied appropriately by clinicians. Access to care is another problem. Access to timely appropriate care is unacceptably long. A number of studies, particularly by Mary Lynch and her colleagues at Dalhousie University, have shown this as well as others. There's relatively few pain clinics, especially those providing multidisciplinary care in Canada. There's a limited geographic distribution of these clinics. Most of them, the great vast majority, are in urban areas, so if you live in a remote area of Canada, it's much more difficult for you to find access for appropriate and timely care of your pain problem. There's a limited number of healthcare professionals with sufficient knowledge or training about pain. I alluded to that in some of my recent slides about the problems with pain education. There are limited treatment options for many chronic pain conditions. So there needs to be more research into ways to improve and diversify effective pain management approaches. And there are limited cost coverage or availability of some management approaches through third-party or provincial drug schedules and so on. So these exist despite such access being a basic human right, as I pointed out before, that's recognized by the United Nations, the World Health Organization, and the International Association for the Study of Pain. So we need to improve access to timely and appropriate pain management. And some of the approaches that could be used here to ensure sufficient number of accessible pain clinics offering timely and appropriate multidisciplinary care exist in Canada, to establish more educational programs to provide pain specialists, to arrange accreditation of these programs and pain management clinics, with pain management or medicine becoming a recognized specialty. And I'm happy to say that there are now have been recent initiatives that look very likely to result in pain management or medicine being a recognized specialty in Canada. We also need to advocate to government policymakers, to insurance companies and so on, to ensure evidence-based management approaches are widely available to pain management, recognizing that we need to also ensure that mechanisms are in place to ensure that pain medicines are not abused by others. And then we also need to link with and build upon analogous processes that are being developed internationally. For example, I was involved in an International Association Study of Pain Wait Times Task Force which came up with guidelines for what would be appropriate wait times, maximum wait times for patients with certain types of pain conditions. And finally, pain research challenges, resources and funding. So it's well recognized that Canada is a world leader in many pain-related basic science and clinical fields, and yet there's a relatively low proportion of pain researchers compared to other health science fields. And linked to this, unfortunately, is that the funding for pain research in Canada and in the USA is also disproportionately low. This shows some data from another survey by Mary Lynch, where for the years 2003 to 2008, she looked at the average pain research funding in Canada, and you see province by province. Now, clearly, Quebec and Ontario have gained the bulk of that pain research funding, but the research funding amounts to just $17 million a year. Now, $17 million a year may sound a lot of money to most of us, but in fact that represents less than 1% of the total budget that the Canadian Institutes for Health Research use to fund research. And it's less than 0.25% of the total health research funding in Canada. So of all the monies that go to fund health research in Canada, whether it's from the CHR or from private industry, pharmaceutical companies and so on, less than 0.25% goes to fund pain research. And comparable figures exist in the USA, where the total for NIH funding is less than 1% for pain research. And for comparison purposes, we're talking about $17 million a year here in Canada. Cancer research funding a few years ago, it's higher now, was $390 million a year. And yet cancer is not as prevalent as pain, chronic pain conditions in Canada. So the limited human resources and funds applied for pain research are disproportionately low, considering the enormity of chronic pain and its socio-economic impact in Canada compared to other less common conditions such as cancer, heart disease, epilepsy, arthritis, HIV/AIDS. So we need to improve the knowledge base and understanding of pain, especially chronic pain. And some possible approaches to do this include increasing human resources with increased opportunities for training basic science and clinical pain researchers, to increase pain research funding and focus on pain, research on pain, to develop better models of chronic pain, to clarify mechanisms involved in the transition from acute to chronic pain, to utilize recently developed and emerging technologies in, for example, brain imaging, or molecular medical genetics, for example, to increase emphasis on inter or multidisciplinary pain research, to apply new basic science knowledge and evidence-based principles to clinical pain research, and to develop clinical databases in epidemiological and randomized clinical trials. So in summary, there have been some remarkable advances in the last 40 years in our understanding of pain mechanisms and in pain diagnosis and management. Nonetheless, considerable gaps in knowledge and issues still exist, but there are several opportunities, I believe, to enhance pain understanding and management which I've identified. And I think that most crucial is the need to, first of all, enhance pain awareness and education. For example, increasing pain curricular time in the health professional schools and ensuring knowledge transfer and application to and by clinicians. And this needs to be done by more effective interactions between pain clinicians and researchers and the public, government and policy makers, the media, and patient advocacy groups, for example. We also need to improve access to pain care so that patients in pain receive timely and appropriate care. And I gave some examples where this could be done, for example, ensuring sufficient number of accessible pain clinics offering timely and appropriate multidisciplinary care exist in Canada, and also by instituting accreditation requirements and improved standards of care, incorporating care for pain patients. And then also increase pain research resources, emphasis on increasing human resources and funding levels, on inter and multidisciplinary and translational research. I gave examples of those as well. So, thank you, merci beaucoup for your attention, and I'll entertain any questions that you might have. I guess I'll hand over to Tanya now.
Great. Thank you very much, Barry. That was a wonderful presentation. I wrote quite a few statistics in there that I was not familiar with either, so that was really wonderful. Thank you very much. And
Okay.
I think I'm going to hand it over to Anne for some of the questions.
Mm-hmm. Yeah, thanks, Tanya, and thank you so much, Barry. That was an excellent overview of the prevalence of the chronic pain situation, and I can see why you call it a crisis. However, you've made some really good points about where the impact can be made in terms of changing access and education, and it's good to know a lot of the groups as well that are doing that kind of work. So let me get to a couple of the questions. We have quite a few, and I don't know that we'll be able to get to all of them today, but we'll do as many as we can. One is regarding the process, I think, when you described in your earlier slides. This is related to that, and the question is, once a chronic pain is diagnosed, what kind of time delay does neuroplasticity engage, and how long would it take to create new pathway?
Well, studies by ourselves and others have found that within minutes, neuroplasticity in the pain pathways can occur. But importantly, for example, in acute models that were studied, in acute pain models that were studied, the neuroplasticity is reversible. So it doesn't necessarily, you may develop the neuroplastic change, the so-called central sensitization, but it's not permanent. It doesn't become maintained. It's only in certain chronic pain states where the central sensitization that may develop within minutes or hours becomes entrenched, and it's very difficult to break down that neuroplastic change and make it go away. So and the time frame varies. As you saw in one of my earlier slides, chronic pain is part of many many general medical conditions, as I pointed out: arthritis, diabetes, cancer, etc. And it's hard to put a timeline or a general timeline on what is the time frame for the development of and maintenance of central sensitization, because it will vary depending on what the disease state is. And so that we can't come up with just one time frame. Depends on what the chronic pain state is associated with.
Okay, thank you. Related to testing, now this has a couple of technical references I'm not familiar with, but are the chemicals such as glutamate, BDNF identified via blood test or another type of test? And I guess associated with that question is, can these tests confirm many cases of chronic pain that go undiagnosed?
Let me just go back to that slide. Can you see what I'm doing here? I'm going back to the slides. Okay, I wanted to make sure that was coming through.
Yeah.
Yeah. So going back to this slide here that I showed earlier on, as I pointed out, there are substances that are released from the nerve endings after they've entered the central nervous system. Substances such as the person just mentioned, glutamate, that can be released. But this is happening within the brain, right? And most of this will not necessarily enter the circulation, blood circulation, for example, so that you can determine that there's an increased level of glutamate in this situation. However, there are situations where some of out in the peripheral tissues, glutamate, for example, is also involved in exciting these nerve fibers. And studies by ourselves and others have found that in patients, for example, with a condition I referred to earlier, temporomandibular disorders, where there's pain in the jaw muscles and in the joints, temporomandibular joint, the jaw joint, there can be increased levels of glutamate in those muscles, suggesting that glutamate detection in muscles might prove to be a biomarker for temporomandibular disorders. This is still an emerging field, and certainly can't be definite at this stage. It's still research is being done whether this would be appropriate. But likewise, within the brain, I mentioned that there are these descending pathways that release various chemical mediators. Some are so-called endorphins or enkephalins, for example, and some of the audience may have heard of these neurochemicals, endorphins and enkephalins, and their main function for most of them is the different types of them, but for most of them their function is to suppress this pain transmission process, either at this first synapse level or at high levels of the brain. And it's possible now with brain imaging studies to detect the levels of, for example, some of these chemicals or some of their precursors in human brains. So we are slowly going towards or developing techniques that can, I think, in the near future will be able to be applied in humans to help detect whether there are changes in brain chemicals that may be associated with particular chronic pain state in a patient.
Okay, thank you. Very exhaustive explanation. That's great. There was one comment here: medical codes in Canada are reported as to the type of pain condition, as NS has no chronic pain code for MSI. Is this Canada-wide?
I don't know. I'm not a medical medical doctor, so I don't know.
Oh, right, of course,
particularly for MSI, I am aware of the general nature of these codes, etc. But for MSI, I don't know. I'm sorry.
Mm-hmm.
We can check into that and maybe put it on the blog later on.
Sure. Okay. Can you give examples? I know you're quite familiar and have obviously very involved yourself in a lot of the initiatives to advocate for change. Can you give some examples in your experience of how provincial or national pain advocacy groups in Canada have successfully lobbied for changes at the government and funding level?
It's not easy, as I guess is one of the bottom lines. Mm-hmm. But these groups that I showed before, for example, have been the lobbying by the Canadian Pain Coalition with the Canadian government, particularly the Senate, was effective in the Senate recognising that the need for having a National Pain Awareness Week, and that only happened, as I said, about seven years ago, something like that. Now, pain advocacy is a quite relatively new area. It's only been really being seen for any particular association over the last decade. The Action Ontario, for example, was formed only about 8 years ago, and it advocates for people with neuropathic pain. It's had some success with the Ontario government in having the Ontario government, we think, recognising the need for a pain strategy that encompasses not just legislation related to drug control, for example, but taking into account the multi-dimensional approach that needs to be taken for pain, looking at not only, as I say, drug abuse, but also drug control, but also access to care, education, research, and so on. It's still early days for many of these associations. The Quebec group has had some success in lobbying with the Quebec government to come up with funding for research and clinical activities related to chronic pain in Quebec. So there have been some recent success stories, and hopefully that's just the start. That with more and more people involved, hopefully many of the listeners will be interested enough to join these advocacy groups and lend a hand in bringing pain awareness to the attention of government and other policymakers.
Mm-hmm. Yes, and we'll for sure put up the links to all these organizations on our website, and there's a few here that I don't know if we have them all yet.
Yeah, this is just some. I just chose a sample of some that represented national or regional or provincial activities. There's also action groups, for example, out in the Maritimes, and there's one out west as well. So that depending on where you're living, and if you're interested in advocating for neuropathic pain, you could join one of the action groups.
Okay, that's good. I might get that information from you later. Okay. I think we might have time for one more question, and I apologize to people who have submitted a lot of these questions. We'll try and maybe condense them, and perhaps, Barry, if you'd be willing, a few of them to answer, and we can post things after the fact.
I will as best as I can, yes.
Yeah, and I'm aware of your time, so we'll consider it just a few questions. Now, in terms of education, why do you feel it is that many doctors don't support alternative treatments when they actually help? Or complementary medicine therapies? Well, or is that a bit outside of your realm as well?
No, not completely. Well, there's a number of complementary alternative medicine approaches that are being advocated for use for chronic pain conditions, or certain chronic pain conditions, ranging from herbal or aromatherapy right through to, for example, acupuncture, etc. But for most of these approaches, however, the evidence base for their effectiveness is rather limited, and I think it's still early days before we can say that in fact they are effective. They may be effective in some individuals, but they're not necessarily effective for all chronic pain states or for all patients who have a specific chronic pain condition. So there needs to be more research done in this area. It's interesting that the person who, one of my colleagues at McGill University, Dr. Catherine Bushnell, who is the recent president of the Canadian Pain Society, she has just been recruited to the U.S. National Institutes of Health to head up a group to study complementary and alternative medicine for pain. So hopefully through efforts of her and her colleagues and others, we'll have a better scientific understanding of the applicability or not of a variety of alternative medicine approaches for pain relief.
Mm-hmm. In fact, we had Catherine Bushnell on our last series talking primarily about brain imaging.
Imaging, right.
Yeah.
Right.
So that's very interesting that she's involved with that now.
I want to thank Dr. Sessle for joining us and for giving us such a wonderful presentation. And also thanks to all of you for attending. And we hope to see you on August 14th for our next one. Thank you very much.
Thank you.
Thank you.